The syntax score serves as a plausible code for the feasibility and appropriateness of PCI or surgery. But in Taiwan, the patients are usually less inclined toward surgery. So do you think that the syntax score is equally applicable to patients in Asia, since you just mentioned that you know what's going on in Far East, at least in Japan?
Yeah, I think it's a good question that I've heard many, many times. If I go to Indonesia, if I go to Vietnam, if I go to Japan, I heard that question many, many times. Of course, there are differences in culture. I know, for instance, that the Japanese does not want to have a foreign body, doesn't want to have their chest cut in two. So that exists. I think from my point of view, what I have tried in my life is to predict, to inform, and to have a long-term follow-up, to follow my patient for a long, long time. Now comes the difficult time where you have to inform the patient. And you know, the inform the patient is one of the most complicated things because you have to provide the patient with information. And the patient is pleased if you can give them a personalized future. If you could say, if you do this, you will have that. If you do this, you will have that. And that's very difficult because the instrument is not yet perfect, but it's clear that with machine learning, the fact that, you know, in the past we were always thinking diabetes and unstable angina and that's it. That was in our brain, and we project that on the patient. But I think that in the future, when you go into the hospital and something like 40, 60, 80, 100 parameters is recorded, and you give that to the extreme boost gradient machine learning, and suddenly you see something emerge. Okay, that's what we call the derivation from the machine learning. Then you have to validate internally in your population, and then you have to validate externally in the different population. And then you start to realize that there is truth. You know, when we went to the Credo Kyoto from my friend Kimura in Japan, he had 7,000 patients, either three-vessel disease, either treated by surgery or treated by PCI. And then we applied the Syntax 2020, that's the publication in JAC. I was very impressed that in these 7,000 patients, the predicted mortality and the observed mortality were very close. So it became, for me, very difficult not to say that to the patient, that the chance that you will be a dead person over 5 years, 6 years, 7 years, I think that's a question of time. I think that culture is always there, but I think the information on internet, at a certain moment, the patient, at least in Europe, start to consult specialized internet, also with AI, and start to realize if I take this treatment, I have more chance then. So medicine is a question of flair, is a question of social contact with the patient, but I think we have to try to introduce some kind of science, some prediction, and then it is our job to tell the family and the patient that's what's going to happen. And I know it's difficult, and I know that in some country it's easy to follow the patient for 2 years, 3 years, 5 years, 10 years. In other countries, it's much more difficult because there is a movement of the patient from other places and other countries, etc. But I think put you in the position, in the shoes of the patient, the day you are confronted with the problem, I have a three-vessel disease with 2 bifurcation and a total occlusion, what is the best for me, okay? How would I be after the anesthesia and the cut in my chest and so, and how good will be two bifurcation plus a total occlusion and 100 millimeter of stenting in my body? That's really the question you have to raise, yeah?
Okay, thank you. And as the piece of work shared by Dr. Tsai, the FIRE trials work on the piece complete or culprit only PCI for older patients with MI. It shares a valuable insight into physiology-guided PCI. Well, now we understand the concept and idea of physiology-guided PCI. I wonder when the imaging-guided PCI is going to be classified as a class 1 guideline, a class 1 indication in the ESC guidelines, since we all know that Dr. Gary Mintz has a lot of concern on that matter, and we all know that he's going to share his point of view tomorrow. So I would like to hear more about Professor Serruys and Dr. Tsai's perspective on that issue.
So in the ESC 2023 guideline, the intravascular imaging used for ACS patient has already been elevated to 2A. And then in the 2023, we see the publication of the presentation of the October trial, the Illuminium 4 trial, the Octavus trial, and the simultaneous meta-analysis done by Greg Stone and et al. So we know that based on the meta-analysis, the outcome with the PCI guided with intravascular imaging is indeed superior. But individually, this study tells us that using the intravascular imaging to guide complex PCI is superior. But it may not tell us exactly the population of FIRE. The older population that may if you are, especially when you are talking about in the OCT context, that may have a weaker kidney, and also in the population that has STEMI or non-STEMI. This is a slightly different population that will prevent the guideline committee to elevate it, the level of recommendation. But I think they put it in 2A is an encouragement for the people to use intravascular imaging to treat and to guide the patients. And also there is a 2B recommendation when you cannot find a culprit lesion with the OCT. That's also sometimes happens when you have a patient that presented with STEMI or non-STEMI, but you cannot find a clear focal culprit. Sometimes the OCT will give you very surprising results. So I think that we will need more better clinical trials. That's definitely in the pipeline and going. But based on the current study, we can say that, okay, if you have a complex lesion, you treat with intravascular imaging guidance. But in terms of ACS, the guideline recommend 2A, so you probably should try to use it.
Yeah, I'm always looking in the future. And I think that I've been there from the beginning with balloon angioplasty, stent, coagulation. I mean, at some point we were giving 5 drugs after stenting, Persantin, Anturan, antivitamin K, heparin, etc. So I think that what we could see in the future, I don't know when, is that, of course, dilatation and high flow is something very good for the thrombogenicity. I mean, when you have high flow, you reduce the risk of thrombogenicity. But I can tell you what we should try is not to give a drug who let bleed the people for something which is so focal and put on one side. So in my history in 1999, I developed with Cordis an heparin-coated stent. And that heparin-coated stent was very good. I mean, it was a covalent binding. It was the Carmeda principle. I discovered that coating in Sweden because the intensivists were treating the people with a crush syndrome. You know, your lung has been crushed. You have to be in the heart-lung machine, but you cannot give heparin to the patient, otherwise they will bleed in their lung. So what they did, they cover the heart-lung machine with this heparin coated. And the heparin coated take the thrombin on the heparin, the antithrombin come, get separated of the molecule, and the heparin can work for the next molecule of thrombin. Now what happens, and that's very interesting, is that we did a randomized trial with 800 patients. 400 received the heparin-coated stent, and there was one single thrombose at that time, without IVUS and without anything. And by the way, we had tested that in the animal, crushing partially the stent in the fistula veno-arterial, and even when the stent was crushed, if it was heparin-coated, there was no thrombus. So you can ask yourself why we didn't use that. Two reasons. First, other companies try to do also heparin-coated. That's the marketing competition. But they were just painting the stent with benzoyl column of heparin, and immediately it was washed out. So they were competitors with pseudo heparin-coated. The second point is that on the same year, I discovered the cipher in the animal work. I mean, in New Jersey, I went there and I saw for the first time the heparin-coated stent in animals. So you must understand the industry who said, we can develop the heparin-coated and work on 1 to 3% of stent thrombose, even 4 if you want. But with the eluting stent, maybe we will reduce the restenosis rate from 20% to 0%. So the choice for the industry was easy, and the heparin-coated was forgotten. It's still used, but it's forgotten. I use now in biodegradable grafts to keep the graft open. So that's an interesting story. Now, what is the next in the pipeline? The next in the pipeline, and try to remember that, CD31. CD31 is a very special small molecule, very small. It's an epitome. And it is what we call a transhomophilic cell or milieu. That means that when you coat on the metallic stent, the CD31, the platelet does not recognize the metal and say, oh, I have a perfectly endothelial cell because it's covered by CD31. The platelet goes away, way to speak. Vice versa, the endothelium cell says, hey, there is a friend there, he looks like endothelium, I'm going to join him. Therefore, transhomophilic, okay? It's attracted the same. So imagine that you put that on the stent, and we have already done in the animal. You could completely eliminate P2Y12 because you have no need. The stent in itself is no longer thrombogenic. So don't forget that that whole story of P2Y12 has been introduced because the stent was thrombogenic. So the first action, the first logical action is to make the stent non-thrombogenic, and that's coming, that's coming. So when I saw the technology last year, I saw in aneurysm of the subclavian in rabbit, I had the same shock than when I saw the first drug-eluting stent. I said, oh my God, if it does work, it could change the whole world. We'll see if it happens. But that's something that I'm really looking at, yeah? So that's a little bit of futuristic vision. But try to remember CD31 and go to a textbook and read about these things, I mean. And don't confuse that with CD34 that I did also before, which is a big molecule capturing the APC. But that didn't work, yeah? Okay, very good question. Any other, because I saw we receive a lot of questions there, so I put here on the list, this pint of champagne, I try to answer the question, yeah? Yeah. Eugene.
Thank you for the excellent talk. I have a few questions. I think in the ESG guideline on the myocardial revascularization 2018, I think syntax 2 is not really incorporated in that guideline. So they still use the syntax 1. So do you think that maybe in the coming years, the updated guideline will recommend use the syntax 2 or even syntax 2020 for the recommendation for the myocardial revascularization?
Yeah, I think let me tell you something about the guideline. We have a big problem in the guideline in Europe and in the United States. You know, the last time that I was involved in the guideline on revascularization, that was 2011. I have just done the syntax study. There was 40 people in the room in the writing committee, and Serruys said, we have to put the syntax score in the minute. We have to put in the guideline, and we put in the guideline. What I'm telling you is that when you do the guideline with expert, the expert use their knowledge and somewhat bias the guideline. So now the European Society of Cardiology, the ACC, and so select non-expert to write the guideline, so that it's not biased by their own knowledge and their own research. The problem is that it became very, very, very slow. Okay? So you see now funny things. If you see how many trials we have with P2Y12 for 1 month with aspirin, more than 60,000 patients. How long are we going to wait anymore? Yeah? So many of the questions that you raise is somewhat blocked by the fact that non-expert is dealing with this information. Specifically, your question was?
So I mean the syntax go 2 will incorporate in the new guideline. Yeah, but I understand maybe that's the story about the guideline. But I think the same story is I think there are paper from Robertson and also Davide, they recommend to downgrade the PCI for the low syntax score in syntax score patient for layman PCI from CAS 1 to the CAS 2A. But I was somewhat surprised by this recommendation also.
Yeah, I mean, if you have seen in the United States, three-vessel disease, CCS, is a 2A, okay? So the certain surgeons were really upset by that, and the surgery is put at the same level of PCI. So they were unhappy because they have been downgraded and put on the same level of PCI. Why a lot of data show that in three-vessel, very difficult three-vessel disease, garbage is better than PCI. So the guideline 10, 15 years ago was like the Bible. Everybody believed. Now, every time that guideline is published, there are a counter group saying that's not true, I disagree with that. So that's the danger where we are now. And then the community start to say, well, guideline, should I follow the guideline? Because it's so slow, it's so behind, and it's so controversial sometimes.
Okay. So my last question is about the syntax 2020. In the syntax 2020, we counted the 10-year mortality and 5-year mass rate, provide 2 digits, 1 for PCI, 1 for cabbage. But is there any recommendation? What's the threshold between these 2 digits? Is 4.5, or how to use this in the real world practice?
The first answer to your question is that nothing is definitive. I mean, that if you want to have something of quality, you have to get adapt. That's the reason why we are moving this 2020 to machine learning, because obviously you improve the prediction, and improving the prediction is the goal. So I would say remain tuned to the syntax, because he will move, he will change all the time. For us, it's still a useful instrument, but you have on regular basis to validate. And I'm sure that I was pleased when we validate in the Far East population of Credo Kyoto, because I was a little bit afraid that it will be very different, and it was not different. But certainly you will see. Today with the machine learning, we don't know exactly how much we do, because basically the anatomic syntax core is still very strong. Okay, whatever we do, the surgeon improve and we improve. So at the end of the day, the ratio remain a little bit the same. But I'm sure that when you will get a lot of biomarker, they will have a lot of impact on the thing. Either you modify the biomarker, you eliminate your LPA from the blood, you eliminate your CRP. That's what I don't know what is going to happen. Because in the last 3 years, it's amazing to see the silencing microRNA eliminate a component in the blood. You know, LPA is genetically determined. It's not what you eat. It's not your exercise. You measure that one time in your life, and it's enough. And a quarter of the population has LPA too high. That's billion of people. And you have now a drug which eliminates from the blood. What does it mean? Does it mean that we are going to see 250,000 of people reducing their myocardial infarction? So that's for the next decade. I mean, the young people here will see that for sure. And I'm not talking about gene editing. One single injection, you modify 2 letters of your DNA, and suddenly your cholesterol is 50 milligrams for the rest of your life. Okay? So that raises 2 questions. At the age of 20, should I measure my LPA? And if my LPA is 70, 100, 120, I am a candidate for gene editing on the LPA? That's the question that you will have after 2030, I think. Yeah. Think about your next question, and we have a half scallop. Yeah?
Professor Serruys, it goes without saying that you are a living legend in the PCI world, having conducted on all the trials from everything, including the balloon catheters and metallic stents, and then BVS and DCB, and then pioneering the state-of-the-art leave nothing behind strategy. So I'm curious about your take on the evolution of the evolution of the PCI history. What do you think were the game changers in every stage of that history? And in the context of complex PCI, what's crucial for the leave nothing behind strategy if stents are still in the picture?
Yeah, I think that's the first comment that I would do is that in my life, I've seen 2-3 times the same principle coming back. And every time it comes back, it improve, you know? Stent is a good example, balloon is a good example, also bioabsorbable, you know? My first series of bioabsorbable is the year 2000 with the Hideo Tamai Igaki. I did 7 patients. It was thermolabile, so if you put in hot water, it was self-expanding. I stopped because there was some dislodging. And then I did a second time in 2006, I think third time in 2008, and I'm still working on it. And I think at some point it will work. If you think calcium, I mean, we have been thinking about the calcium for a long time. Don't believe that lithotripsy is something new. No, it was there before, but it was not applicable. You have to miniaturize, you have to increase the... John can tell you that in the year 2000, in the Grunzig lectures at the ESC, I present orbital. You could see on my slide, I have seen these Russian inventors. The diamond that he was putting on the orbital was not so good, but the principle of the eccentric rotation was there. I present that in 2000. It took almost 20 years to get in the field. So many things get in the field. You take stenting. Charlie Daughter did the dogs with self-expanding stent in 1966. It took 20 years to put the wall stent in the patient, and it takes another many years to get the drug-eluting stent. So don't believe that the progress is fast, and believe that things which are being present come back. We were discussing before the dinner. Today, I would reintroduce the perfusion balloon. I don't know if you have worked with the perfusion balloon, combined with the eluting balloon. Okay? I'm sure it will work. I'm sure you will be able to deliver a lot of sirolimus in the vessel wall. So everything come in loop and loop and loop until it works, yeah? You know when the first stent was implanted in animal? You will not believe, 1906, by Alexis Carrel, which was a Nobel Prize, became a Nobel Prize. And at that time, photography was not existing, daguerreography was existing. That's a kind of a drawing of black and white. And he put a tube of aluminum in the aorta of a dog. So that was the first stenting, yeah? So it takes time, yeah?
Okay, and Dr. Tsai, the current ESC guideline recommends complete revascularization either during the index PCI or within 45 days. And so, since we all know that you were trained in Taiwan before you visit the Galway University, I would like to know that in Taiwan, a significant number of patients also presented with renal insufficiency with a rather high prevalence of dialysis over the last 2 decades. So I am curious about your perspective on whether the ESC suggested interval of 45 days is equally applicable to Taiwan, given the variations of body weight and age and renal function, and of course the contrast medium usage during the PCI.
I think in Europe we don't have such a high incidence of hemodialysis. I think that that's really something which is specific for the Far East, also Japan, because the hemodialysis is very well reimbursed in Japan, so a lot of people are benefit of that. For me, I showed a slide, either 60 ml glomerular filtration, you pay the price after 10 years. 30 is even worse. The only things we can do is that, of course, you have the treatment of the renal failure that can be all kind of therapy. But in terms of PCI, I think we have to do PCI without contrast in this patient. And that's doable. That's doable. So today, I used to work when the people have a very bad kidney function. I was to use in biplane, okay? Then I was doing one film with 8 cc of contrast, and then doing the rest with IVUS and guide Y. So in biplane, I had continuously the video playing, and I was just moving the Y along the vessel, and then advancing IVUS, because that doesn't cost any contrast, and then putting the stent where I've seen the IVUS. So today, the GPS system or the sync vision, that's a kind of technique to be used in patients with bad kidney function. And one of the big proponents of that is Gabi Escanet. He has done, he goes always about angioplasty without contrast agent.
Yeah. I can add a little bit more point about that. So if you look at the more vulnerable patient to have the contrast-induced retinopathy, you can look at the FIRE trial. In the FIRE trial, the safety endpoint is including the acute kidney injury, because that was the primary question they were asking. So in the FIRE trial, every patient had to require to be, if you are randomized to physiology complete revascularization arm, you need to be revascularized in the index admission. And a lot of physicians, they know the patient is pretty old. The median age is 80, so they don't want the patient to go through another puncture and another diagnostic angiography, because each diagnostic angiography can take like a dozen cc's of contrast. So they use the QFR or use the wire to determine the patient, whether the patient can be deferred. So in the fire trial, the safety endpoint, there is no difference. And they do make some adjustment in their technique to reduce the contrast. And also in the BioVasc study, you don't see so much acute kidney injury in the arm that has been randomized to immediate revascularization. And in that term, we can also consider how other technique that can reduce your contrast dose. So of course, the ultimate target is to reduce that as much as possible. You have when engaging the guiding catheter, there's a low contrast strategy that you can engage and inject saline and to observe the ECG change. That way you can reduce the testing dose. In the diagnostic angiography, there's a cardiac sweep function that is available in some brand of the scan C-arm, that you can scan the entire left side or the entire right side just with one contrast injection. Of course, you need to use biplane and IVUS to complete your procedure. I think that in the Euro PCR this last year and then in other meetings, there are a lot of live demonstration of low or even sometimes zero contrast PCI in complex patients. So we know that this is doable for even for the complex patient. Yeah.
In your talk, you talk about the long diffuse lesion. It's not good for the PCI or bypass surgery. I want to know if we face the patient, a small vessel and also very diffuse. For in the current situation, what's your treatment recommendation for this kind of patient?
You know, there's always two things that you try to achieve for your patient. Number one, reduction of the symptoms, because that's the daily life. So you want to do that. And on top of that, you can have a prognostic benefit for the patient, then you have done a good job. Now, it's clear, for instance, that Carlos Colle, when he did his pullback during pullback of the pressure wire, mechanical pullback. I mean, he was using the volcano pullback of the pressure wire during hyperemia, could really show that some of the curves were really linear. There was no place where there was a dip. And then the question is what to do, where to put the stent. And I think in practice, without this sophistication, there are people who put very long stent, and I think that in the long term, they get punished, quote unquote, by two things. The angina does not improve, and the risk of stenosis and thrombose and so increase. So it's really a big issue. Now, the question is that, are you dealing with diffuse disease, calcified or non-calcified? That's also a big issue. And I think that more and more we are going to try to find out what is in this diffuse disease, because Collet, when he did this pullback, showed that in diffuse disease with the the index very elevated or very low, below 0.78, these patients, 52% had angina at 1 year. So it's very difficult also to improve the angina of these diffuse disease demonstrated by PPGI. As I said, we have tried, if it's calcified, it's maybe an option to try lithotripsy and to enlarge that vessel. For the diffuse without calcium, I think that the pharma will be one option, very aggressive pharma. You know, my friend Yagat Narula, I'm sure you know Nagat Narula is a famous radiologist in Mount Sinai. We work every week. And one day he said, I'm jealous of Jean Bonwald. I said, you are jealous of Jean Bonwald. Why? Yeah, because his LDL cholesterol is 21 and mine is 27. Okay, fine. Not so long ago, and I think you were there, as a joke, in the beginning of the Zoom, I said, how is your LDL cholesterol today? Oh, he said, very good, it's 7 milligram. 7 milligram. So he's combining rosuvastatin, ezetimibe, and inclisiran. Now you can ask yourself, what is the function of the LDL cholesterol if somebody with a brain like Yagat Narula can tolerate 7 milligram, okay? In a baby, it's okay because everything goes to the myelin of the brain. I mean, that's the reason why the baby has 20 milligram, 25 milligram. But at 65 or 75, is that good to have 7 milligram of, but it's doable. It's doable. So I think that if it's doable, you can expect a major change in the pathology of the vessel wall. And that's the big challenge that we are going to see. As I said, I really believe that you have diffuse or not diffuse, the calcified lesion of the elderly, where really we have to improve lithotripsy and all these things. And then you have the young patient who have not yet calcified, but have already soft plaque, low attenuation on the multi-slide CT scan. You know, during the Korean War, they did an autopsy of a lot of GI. The atherosclerosis was there at the age of 21, yeah? So that's the moment where we have to recognize the disease by biomarker, genomic, and so, and start selectively to treat with very potential things. You know, the COVID is all silencing microRNA, okay? MicroRNA. Billions of people have received microRNA without consequence, okay? So I think that's a major step. We had, after the war, the antibiotic, we controlled the infectious disease. I think that at some point we will start to control the atherosclerosis. I think it is in the pipeline, yeah? You know, Zek Katirezon take animal, he increased the function of PCSK9 by gene editing, and the animal goes to 450, okay? And then he make a second injection to remove the function that he has created, and the animal goes to 50 milligram. So that showed the power of gene editing, at least in animal, but it's already in the human. The first 10 patients has been treated. So I think that field, especially for the young people, you may have started your career by pushing balloons, stent, etc., but you can end up in a very different way. And you will have to do that on time, yeah? Because you need to know the minimum of molecular biology, etc., etc. So don't put that on the side, keep reading on it, because that's going to be the therapeutic instrument very soon, yeah?
Thank you. And I have a question for the, Dr. Tsai. Yeah, in the fire trial, we already know the physiology strategy is better than the copulation tree strategy. But in our clinical practice, do you
always use the FFR guided plus the imaging guided because in Taiwan, you know the natural health burns the wire and also the IVRS OCT, and then, usually we always choose one. Yeah. Do you always use two?
Can I receive the voice?
I think that each region has its own strength and weakness. If you see I would say that the miserable number of IVAs and OCT use in the European region in the real practice, 4 to 5%, then you see that, okay, they have their weakness. And actually, in the Italian registry, the use of the physiology wire in their real practice, their real practice is like 15% or less. So with the national health reimbursement, you need to take more scrutiny on what you use. Of course, in my previous in Taiwan, that probably opening an IVAS catheter is much easier than opening a FFR wire in terms of the money consideration that you put. Because when you open an IVAS catheter, you're already doing the PCI, then it's probably okay. But yeah, that's indeed an issue. But we have, I think that opinion leaders and the doctors as a whole need to negotiate with the competent authority about a payment, because if the fire trial and indeed the other trials show that this is beneficial, then maybe in a very health economic way, in the sub-analysis of the fire trial, they will compare between the QFR and the FFR, or invasive FFR and YFR. And there are many other studies that's already ongoing and is going to present that with the comparison between the QFR and the invasive wire FFR. So maybe we can negotiate that if the health insurance cannot pay for the wire, maybe you can consider pay for the software, because it is cheaper in the long term. That kind of things that if we know what is good for the patient. Like we know that TAVI is good for the patient, but it's not reimbursed, so we don't have enough TAVI in Taiwan. But that's something that I think that's our difficulty. That's something that we need to negotiate with them. After all, we still have vote.
Red meat you have eaten today, but you're full of energy, yeah?
I haven't had a bite of that steak yet. Dr. Serruys, in our hospital, we make it a practice to inform the patients' families of the critical conditions, especially when we're dealing with MI at KILIP 3 or KILIP 4. And we typically discuss the potential use of MCS, such as IBP or ECMO. So I would appreciate your point of view as the point of view for the role of MCS, both as a bailout strategy or in prophylactic use, and especially in the context of complex PCI.
That's another example of something who came back and came back and came back. I mean, if you look in the literature, Marie-Claude Maurice and myself, in the era of balloon angioplasty before stenting, we did in total, I did 7 patients, and Marie-Claude did 41 patients with heart-lung machine. So the heart-lung machine was coming in the cath lab, and we were doing PCI for very complex patients. Now, what was interesting with the heart-lung machine is that at some point, the patient stopped to breathe, yeah? Because the CO2 in blood is so low that it doesn't need to breathe anymore. So the big thing was to, from time to time, to say, please breathe, because we didn't want to have atelectasia in the lung. So that's a little bit the historical to say that at that time, patient that the surgeon didn't want to do, we were doing with heart-lung machine and balloon angioplasty. And in my case, it went wrong because at some point the surgeon discovered that. And the surgeon one day came into the lab and said, Patrick, perfusion, that's my thing. Heart-lung machine is my field. So that's it. So I stopped to do that. Then I restart with the tandem arts. I don't know if you remember the tandem arts. You do a transeptal, and then you have a big cannula sucking the blood from the left atrium, and then you re-inject in the aorta. Very efficient. I did case where the ventricle was not moving at all, and the mitral valve was not moving at all because there was such suction of the blood from the left atrium. Very efficient. Then I was the first to introduce the LVAT. If you look at the paper in Eurointervention, maybe 15, 16 years ago, I did the impella, and I test all the level of the impella, P1, P2, P3, until P9. And I had the pressure volume loop. I had a conductance and impedance catheter in the left ventricle. So basically, I could see that you have to reach P6 to avoid aortic regurgitation, and it's only when the suction is stronger than the regurgitation that there is a benefit for the patient. Now, I use a lot in the early days when it was not yet accepted in the United States, and I became a little bit less enthusiasm because of few complications. The biggest complication that I had one time is that in the middle of the night, because I was doing the case in the lab, and sometimes I was keeping the impella during the night, yeah? And one impella get blocked in the middle of the night. I came to the hospital, I removed the impella, and there was a kind of piece of tissue in the impella. So I give the tissue to the anatomopathologist, and he said, that's a piece of mitral valve. So, and still recently, it has been described again. So you have to orient your impella in the right way. During a procedure, it's not so much a problem, but when you put the patient in the bed and he's moving a little bit, it becomes a problem. So that's a little bit what I can say about the impella. Now, the French people, for instance, does not use the impella. So it's basically, it's like the DCB. You must have characters. So there are people who say, I don't need the impella. And there are people younger, more insecure, who would like to put impella to, quote unquote, cover their ass in that situation. Recently, when you see, and it's another field, of course, it's not a risky patient, but in cardiogenic shock, Thiel from Leipzig have shown at the ESC that ECMO was not helping for the cardiogenic shock. So the other day we had a new trial where they are combined ECMO and impella. They call that Ecapella, yeah. I don't know. I think that when the myocardium is destroyed, it is destroyed. To do in the early stage, I will fully agree, but in the later stage, what is destroyed is destroyed. I mean, that's what I learned from this ECMO experience. You can normalize the lactate, but as soon you remove the ECMO, they crash again because the myocardium function is not there. So if the ECMO in cardiogenic shock is followed by something like transplant or the new artificial heart, you know, the Matra company has been working with Carpentier, yeah, and they have a pretty nice artificial heart. That's make more sense to me. But to do something very complicated for a long period of time in the cardiogenic shock and nevertheless lose the patient and the two curves of mortality are identical with or without ECMO is very disappointing. Yeah? So the name of the artificial heart is Karma. Carpentier Matra. Carpentier Matra. Matra is a company making race car, and Carpentier is the famous surgeon. So the heart is Karma. If you go to Google, you will see Karma. It's beautiful. It's all plastic, and it works quite well. Yeah. But Impella during difficult situation, yeah. What is a difficult situation? That's complex. I mean, how many times we have treat difficult main stem and did without Impella, and it works very well. You open the vessel, everything goes better. Yeah, it's difficult to say. If there is absolutely no negative side effect, I would be for. But there are some, yeah.
Actually, I haven't had any experience in Impella given the out-of-pocket cost in Taiwan. And so here comes my next question, also related to the health insurance systems. It seems like interventional cardiologists in Taiwan and Japan are more into tackling CTOs than their counterparts in Europe and the United States. So, I mean, regardless of clinical symptoms. So what's your take on whether spending all the efforts and times is really worth it? And do the health insurance system makes any differences in those scenarios?
I think that CTO, and I've been doing that for a long time.
Listened to one of your interview on YouTube. You said you tackled with some CTO in Russia.
Yeah. I mean, I spend a lot of time on CTO. At one time, we create a laser wire. And with the laser wire, we said, okay, we will go through the CTO very easily. And indeed, we were going quite easily to the CTO. But in 27% of the case, you could see that the wire was outside the vessel, okay? Without consequence, because it's a pinhole things in the middle of a magma of necrotic core and calcium, and so nobody had the tamponade. You could find a paper in the European Heart Journal. The name of the trial was Total, and you could see the description of the 27 laser wire going outside. So that's the moment where I started, a long time ago, to do bilateral angiography. And the first time I want to do the bilateral angiography, my nurse said, you cannot do that. You're going to kill the patient. I said, I don't think so. It's not because you inject contrast on both sides. And then I went to see Nobuyoshi in Japan, yeah, and introduced the laser wire. And then I was using this bilateral injection of contrast. Nobuyoshi was not at all interested in the laser wire, but the technique of the double injection became very popular very quickly in Japan. So that's one thing I'm proud of it. Now, CTO for me, there is two conditions, really two conditions. To prove that the myocardium behind is viable and to prove that it is ischemic. That's the key point. If it is ischemic and viable, that deserves to make a lot to recuperate that. But many of the CTO are on scar tissue, and it's cosmetic, but it is not real. The only thing I have seen is that, and I will never forget, an old ladies where I spend a lot of time opening a right coronary artery, yeah, filled in by the LED, okay? And the myocardium did not improve, so probably it was not very useful. But what was not my surprise, and I showed this film for many, many years, that lady came back with a total occlusion, acute occlusion of the LAD. And that collateral, which was not giving blood to myocardium, was still working as a channel in the opposite direction. So that's something which has not been too well investigated, to what extent this tube, this conduit can work as conduit without providing blood to myocardium. But that's only the case where you reverse the collateral circulation. Yeah? But for me, viability and ischemia is the condition. I think the MRI is something that should be done systematically before a CTO. You have seen my slide, 10 years of follow-up. I mean, there's no difference between with or without revascularization, recanalization. It has no impact. The Euro CTO was also somewhat disappointing as a trial. There is some impact on symptoms, but that's it, yeah? So the improvement in prognosis was not clear. But we all know also that when you have a total occlusion and the patient come back with the occlusion of the other vessel acutely, he's usually in cardiogenic shock, yeah? And so there is some logic to keep that vessel open. But I think today, for me, to make something complex, retrograde, etc., it has to be justified. I'm going to give blood to something which is ischemic and viable.